that is Pott's spine, also known as tuberculosis of spine or spinal tuberculosis. Okay, so let's talk about it. Pott's spine, tuberculosis of the spine or spinal tuberculosis. Now see here. Before I enter into this topic proper, let me ask certain questions regarding TB. What is the causative organism of tuberculosis?
Mycobacterium tuberculosis.
Exactly. 100% of the students should answer this, okay? Otherwise, we believe you don't know anything regarding TB or any infectious disease. So this is Mycobacterium tuberculosis, and Mycobacterium bovis also can also lead to tuberculosis. But more common is definitely Mycobacterium tuberculosis. Second question, what is the route of entry of Mycobacterium tuberculosis in our body? Where it goes first?
Into the lungs, respiratory tract.
Exactly.
Air droplets, sir.
You're right. You're right. Through the air droplet, it will enter into the airway or into the lung first. So remember one important point, wherever tuberculosis occurs in our body, that person must be having pulmonary tuberculosis in the past or now. Okay. It is in the past usually. So a good history of tuberculosis infection in the past has to be taken. So that's the point I like to highlight here. Okay, now let's come back to the topic. Tubercular spine forms the 50 to 60% of the total incidence of skeletal tuberculosis. Among the skeletal TB, the three important types of tuberculosis are spinal tuberculosis, or tuberculosis of the spine or vertebra is the number one. Second, hip joint tuberculosis, and third is knee joint tuberculosis. These are the most common one, but among them, the spinal one is the commonest. It is a disease of childhood and adolescence, and it is most common in 1 to 20-year age group. So quite a younger, population is infected, and the most common site in the vertebra is thoracolumbar label. Thoracolumbar label. So let me underline this very important point. Now, if thoracolumbar spine is damaged, and secondarily, if spinal cord which is lying inside that thoracolumbar vertebra is damaged, what are the clinical feature or important clinical feature in the patient? What will happen? Yes? What will happen to the patient?
Sympathetic nervous system dysfunction will occur, sir.
Okay.
Lower compression. Lower limb, sir.
Very good. So you are answering in a right track. That's what I need. I will explain all these things in the subsequent slide. Don't worry. I just wanted to check whether the students are very vigilant or not. Now, remember, if the spinal cord is damaged at thoracolumbar level, the brachial plexus have already originated, so there is no problem to our upper limbs. Only our lower limbs would be affected. That is called paraparesis or paraplegia. Along with that, the bowel and bladder function is also affected. Okay, and some sympathetic nervous system can be affected either. So these are the different points. Okay, we'll talk everything regarding this in the subsequent slide. Let's move on. Now, regarding the pathology, or where is the problem in the vertebra, the disease affects the spine secondarily from a primary focus in the lung or mediastinal gland through the bloodstream. Very clearly written here. So in the beginning, the infection always in the lung. The primary focus is in the lung. And remember, this tubercular organism, has some important characteristic feature. It can be latent for a long time there. And later on, when the immunity of the patient goes down, it can be reactivated, or it can have some reinfection or new infection again. So this is one point here. And another one, the mediastinal lymph node, gland means lymph node, may be affected because of infection in the lung, and through that the organism will enter into the blood, and through the blood it can reach the bone or the vertebra. So this is one of the commonest way. Now in the vertebra, what are the site of the lesion? So these are paradiscal lesion. Paradiscal. Now just think about the vertebra there. Okay, there are bodies of the vertebra, and then in the middle there is a joint. This is called intervertebral joint. Intervertebral joint. That is a disc. Okay, intervertebral disc we say. Now that intervertebral disc has different parts. The central part is called nucleus pulposus, and the surrounding part or the peripheral part is called annulus fibrosus. So what I'm saying here, in the body of the vertebra, the area which is very near to the disc or the intervertebral disc is affected first, and this is known as paradiscal lesion. Okay, paradiscal lesion. Now later on, this paradiscal lesion may be spreading to the central part of the vertebral body. Then it may go towards the anterior part, and it may be towards the posterior part, which is called appendiceal type. So paradiscal lesion is the commonest and the earliest, followed by central body, anterior, and the appendiceal. The initial focus is in a vertebral body near the disc. That's why we call it paradiscal. Paradiscal, then it soon spreads across the disc. The disc is infected secondarily, which it destroys to involve the neighboring vertebral body. Very important, mechanism there. So let me explain again. The intervertebral disc is completely destroyed by the tubercular disease, and then the vertebra which is above or below is also affected. The erosion of the intervertebral disc of the contiguous vertebra lead to disc space narrowing and formation of deformity. So in the beginning, what happens? There is a collapse or there is a destruction of the disc. So what will happen now? The two vertebrae will come closer to each other, and we can see that in the X-ray. The disc space is narrowing there or narrowed. And if the destruction is more, then there will be development of deformity. This deformity is called gibbous formation. Okay, gibbous formation, very important term. We'll talk about that. See there. So what are the clinical features of tuberculosis of the spine? There is a long history with insidious onset. That's what tuberculosis is all about. Okay, insidious onset or slow onset. And there is a long history. There is a localized back pain. The affected vertebra is only having pain, and that is maybe slight dull ache, or it may be worse after standing or walking. And when we press there, there will be severe pain. So always you have to test this one. When the patient comes, you need to thump the central part of the vertebra. Okay, hit a little bit forcefully there. And when we reach that affected part of the vertebra, the patient will wince, means there is severe pain. Another is deformity or gibbous formation. Now this gibbous is an angular type of kyphosis. It is a sharp deformity at thoracolumbar spine level. Now we all know what is kyphosis, isn't it? What is kyphosis? Yes? Who can answer?
Bending of spine.
Yes, yes. Exactly. Backward bending.
Bending, spine forward.
Now, there's a two terms. Exactly. There's both way you can answer. Now, see that the angulation is an acute type of angulation, okay, towards the backward. This is called kyphosis. So there is a bulge formation on the backside. This is called kyphosis. And regarding the tuberculosis of the spine, we use the term gibbous for that. So look for the gibbous or feel for it if you suspect a case of tuberculosis of the spine. This may give you the diagnosis. Another is a protective paraspinal spasm. This is protective. Why the term protective is written there? Because it is an involuntary type of muscle spasm. Whenever there is a disease of the bone, okay, the muscle which surrounds that always develop contraction or spasm. So that can be felt there. One of the very important clinical feature is paraparesis or paraplegia, weakness of the lower limb or paralysis of the lower limb because of the affection of the spinal cord. And cold abscess is an important feature of tuberculosis. Okay, this is a collection of the pus in case of tubercular infection, but there are some important characteristic feature of that pus. It doesn't have features of inflammation there. It doesn't feel hot. Okay, that is a very important feature. Now, what is Pott's paraplegia and why it occurs in a case of tuberculosis of the spine? And what are the clinical features? Let us talk about it. It's a part of this lecture. Now, Pott's paraplegia, okay, occurs when there is a pressure on the spinal cord. But what are the mechanism? Okay, I'll highlight that now. Pressure on the spinal cord may occur at any stage in the course of TB in the thoracic or thoracolumbar spine, and this spinal cord may be compressed by soft inflammatory material like abscess. This is called abscess, a caseous mass, granulation tissue, and a sequestrated disc. Okay, so all these terms are quite easy for you except the sequestrated disc, which may be a new term for you. So please listen here. Sequestrated disc means the disc is completely damaged, we know that. Okay, so if annulus, of fibrosis is severely damaged than a nucleus pulposus part, then what will happen? The nucleus pulposus is herniated. Okay, it will be moving here and there, and it may also be divided into few pieces, and some of the pieces may severely damage, okay, the spinal cord, or they may go towards the spinal cord. This is known as sequestrated disc. So think about intervertebral disc, disintegration here, especially the nucleus pulposus part. So it may be one of the important cause or mechanism of spinal cord damage. Sometimes the hard solid material can compress or damage the spinal cord, like bony sequestrum, means dead bone. Occasionally fibrous tissue is the compressing agent. And sometimes what happens, just think about the situation there. The vertebra is acutely bent backwards. So there is a bit of pulling effect, okay, a bit of pulling effect on the spinal cord, and that part of the spinal cord may be damaged like that as well. Now let's talk about what happens if spinal cord is damaged. Okay, please focus, and I'm sure many of the students will feel very confident here because the central nervous system discussion was already done or over. The onset is insidious, manifesting itself either by motor weakness or sensory impairment in the lower limbs or dysfunction of bladder or bowel. Absolutely. These are the functions of spinal cord, either motor weakness, sensory impairment, or dysfunction of bladder or bowel. Now, the patient may present with clumsiness, incoordination, and weakness. The voluntary movement ability is decreased, and muscle tones are increased, and deep tendon reflexes become brisk. So what type of neuronal weakness is this? Is this upper motor neuron problem or a lower motor neuron problem? Just share and tell me, what is this?
Upper motor neuron.
Exactly. These are upper motor neuron problem. Okay. Now, actually, both Actually, both type of problem occurs there. We talked about this in our spinal cord lectures. At the site of affection, whatever structures are supplied by the nerve which originate from the site of affection, lower motor neuron problem appear there. But below that area, whatever things are supplied, upper motor neuron problems appear there. Okay, so overall, we are talking about the lower limbs now. So lower limbs usually will develop increased tone of the muscle and brisk tendon reflexes. These are definitely upper motor neuron features. Clonus and extensor plantar reactions are also seen. Now, clonus, okay, is another term for exaggerated reaction of the deep tendon reflex. You can also call it is a type of hyperreflexia. But we do this, or we elicit this, a bit differently, isn't it? Patellar clonus and ankle clonus are the two which are usually elicited in clinical practice. And this is rhythmic oscillation. Once you give the stimulation, that is rhythmic oscillation for a longer time, that is called clonus. This is called Babinski reaction or Babinski reflex, extensor plantar reaction. All of these are features of upper motor neuron problem. Paresthesia or numbness may also occur, or maybe there is a sensory level up to a damaged part of the spinal cord. So all of these features are present in, spinal cord involvement because of tuberculosis of the spine. Now, what are the X-ray findings? What we see if we take the X-ray? Destruction of the bone, compression fracture, kyphosis, narrowing of the joint space, and cold abscess may be present, which are picked by X-ray. Now, this cold abscess is not that easily visible on the X-ray, but it will show some density difference there. So that's how you can easily identify it. But let's see some of the X-ray here. Now, see this? All of you, please focus here. Let me use the pointer. So look at this part. What is happening here? The first thing, where is the space between the two vertebrae here? I can see a good space there. See here, I can see a good space there, but actually the space here is increased because the vertebrae collapse here. So this vertebra has moved slightly posteriorly and upward. So there is increased joint space, but this is not the affected side. The affected side is here in this area. So there is loss of space between the vertebra. This is a very important point. Second, there is a collapse of the vertebra. The rounded body like this, I cannot see anymore. See this? This is destroyed or collapsed vertebra. And there is a bit of angulation backward. A bit of angulation backward. So all these features are quite important regarding tuberculosis of the spine. Another one, look at the destruction of this vertebral body. This vertebral body is destroyed or destructed. This is the anterior part. This is the central part. Here is the posterior part. Here is the presence of intervertebral disc. So in the beginning, the infection starts from the paradiscal area. Then it will involve the, this intervertebral disc. Then it will move on to the involving of another vertebra. And some other cases, the infection may start from the anterior side to the posterior side as well. Regarding the treatment of tubercular spine, we need to make sure one important thing, whether the spinal cord is affected or not. If spinal cord is affected, my line of treatment is different. If it is not affected, my line of treatment is different. Remember that. Now, what are we going to do here? See this. The systemic treatment with anti-tubercular medicine before and after the surgical debridement, the careful debridement of the entire focus of the infection, and the successful method to reconstruct for the spinal stability are the key aspect in the treatment of spinal tuberculosis. So if the vertebrae are already badly damaged, if there there is unstable vertebra, there is severe like a degree of kyphosis or gibbous formation, then we need to go for spinal stability. That can be done by, internal fixation. Otherwise, you have to debride. Okay, for example, there is a cold abscess which is giving pressure. You need to remove, drain that. If there is some granulation tissue which is pressing, you need to remove it. This is known as debridement. And anti-tubercular treatment is always necessary. Let's move on. Now, for decision making and management of spinal TB, it can be broadly classified as two groups of the lesion. That's what I told you just now, those with neurological complication and those without. So neurological complication means paraparesis. Okay, that's what we are talking about, paraparesis or not. Now see there, in patient without neurological deficit or without paraparesis or paraplegia, medical therapy is the treatment of choice, and surgical intervention may be needed in relatively few cases. So these are straightforward cases for the treatment or management. You don't need to worry much. Whereas some other, for example, if there is paraparesis occurs already, bowel and bladder involvement occurs already, then medical therapy is the first choice again, but when indicated, the combination of medical and surgical treatment yield the best result. So let me clarify this again. If the spinal cord is compressed, we have to decompress it. There is no other way to save the function of spinal cord. So for that, surgery is necessary. That is known as decompression surgery. What are the anti-tubercular drug? Okay, every student know that. So this is a very easy question at this moment, because you are almost toward the end of the MBBS career. So these are rifampicin, isoniazid, ethambutol, and pyrazinamide. This is intensive therapy. Intensive therapy is given for 2 months, and then isoniazid and rifampicin for a total period of 6, 9, 12, or 18 months is the most frequent protocol used for treatment of spinal tuberculosis. Now you may be confused here. Why so many different periods are there, isn't it? So it depends on the different center. It depends on the different countries. So some countries or some center believe you need to treat for the longer duration. Some believe even 6 to 9 months is enough. So it's purely according to their protocol. Okay, so whatever protocol your hospital or your center is, following, you have to move according to that. So even 6 months may be enough. Okay, and sometimes even 18 months may be necessary. Now, there is another type of tuberculosis of the skeletal system, that is tuberculosis of the hip. Now, if you remember, in the beginning of this class, I told you tuberculosis of the spine is the most common one, followed by hip and knee. So let's talk a little bit about tuberculosis of the hip. According to the incidence, male to female ratio is 2 to 1. Okay, this is not a very important point. So male are more commonly affected than the female. And regarding the osseous focus in case of hip joint, acetabulum, femoral head, and neck of the femur, as well as the whole joint cavity may be affected. But these are the two main parts of the hip joint, acetabulum and the femoral head. Both of them can be affected here. Now, once the arthritis develops, destruction is very rapid. Okay, so just like Pott's spine, it can do rapid destruction of the hip joint also. So that means the femoral head is destroyed, which leads to pathological dislocation. Pathological dislocation with muscle spasm. Now, why it is called pathological dislocation in this case? What is the reason? Yes?
Because of the chronic disease. Osteoporosis.
Because of the weakness of, and a chronic disease.
Exactly. Exactly. Absolutely right. Remember, we have studied about the hip dislocation, shoulder dislocation, elbow dislocation, and even knee dislocation. The most common cause is trauma, severe type of trauma. But here, okay, even slight type of trauma may lead to dislocation, or sometimes there is no trauma at all because of the severe damage to the joint by this disease, then dislocation can occur. That's why we use the term pathological dislocation. Cold abscess is an important presentation here. This cold abscess is the collection of caseous necrosis material. It may point anteriorly in the femoral triangle and posteriorly below the lower margin of gluteus maximus. And it may form a mass there, and we may be confused. What is this mass all about? And when we do some investigation, then it comes out to be cold abscess because of tuberculosis of the hip. We all know what is femoral triangle, isn't it? Femoral triangle is the area which is present in upper third of our thigh. Upper third of our thigh. Femoral triangle. This is very important, structure there. A lot of important, neurovascular structures are present inside the femoral triangle, like femoral nerve, femoral artery, femoral vein, and femoral canal. And in that femoral canal, femoral hernia can occur. So if you are a little bit, confused about this, it is a good time to revise these things on your own. Okay, so let's move on. Now, what are the clinical features? Let's talk about them. Early slight pain in the groin or thigh in the early stage. Okay, slight pain, not that much. And the pain often radiates down to the knee because the capsule of the hip joint shares the same nerve innervation to the knee joint. This is done by obturator nerve. Okay, obturator nerve. So because of this common, innervation, pain of the knee may be felt, pain of the hip, I should say, may be felt in the, knee joint. Later on, the pain is more severe when the destruction is massive. The pain becomes more severe, and it may make the child wake from the sleep because of the severe pain. Even the adult, can suffer like that. Limping is an important, clinical feature. It is partly due to pain and muscle spasm. Limping, the child cannot, completely bear weight in that hip joint. And if the head of the femur is badly damaged or destroyed, and if there is pathological dislocation occurs, then there will be deformity of the lower limb. Okay, you already talked about that in hip dislocation class. Now see this. So early stage and later stage, the deformity may be slightly different. Okay, what are those difference? In the beginning, there is abduction, okay, flexion, and external rotation type of deformity, which may appear owing to the synovitis and distension of the joint capsule. Till now, the serious damage or destruction of the joint has not been done. So this type of deformity occurs. But later on, there will be adduction, there will be flexion, and there will be internal rotation. Just like, okay, posterior dislocation of the hip. The similar type of deformity occurs there also. So you have to remember like that. Now look at this picture, the X-ray here. Okay. Now look at very carefully. This is the hip joint. Here is the acetabulum. Okay. This is the head of the femur. This is the neck of the femur. Here is greater trochanter. Here is lesser trochanter. So this belongs to a child because these epiphyses still have not fused. Okay. So this is a pediatric age group. So there is some, I can see some irregularities here in the acetabulum, and the head of the femur is also not that very rounded one. So probably Okay, cannot pinpoint by this X-ray. We need the help of some other test. So it may be a case of tuberculosis of the hip. Now, at the end, how we manage the condition. Intensive course of anti-tuberculosis agents are essential. Okay, the same types of treatment: INS, rifampicin, pyrazinamide, and ethambutol for 2 months, followed by prolonged therapy in the continuation phase. The complete rest is continued for 6 months. Skin traction or plaster are used sometime, just to make sure the pain is minimized. And in case of dislocation, this is a very, very essential type of treatment. Immobilization is quite important. When there is obvious bone destruction, clearance of the hip joint is necessary. That is called debridement. Okay, and if it is badly damaged or destroyed, then arthrodesis may be performed. Now, what is arthrodesis? Anyone?
And fusing of joint.
Sir, we break the joint and then we surgically make the new one.
Reconstruction of the joint.
The fusion of the joint.
Now, arthrodesis actually means fusion of the joint. Fusion. Now, why this is necessary? Okay, remember, arthroplasty is a reconstruction of the joint, a replacement of the joint. Arthroplasty, don't get confused. Arthrodesis is surgical fusion of the joint, because this joint has lost its function. So there may be a lot of pain all the time when the patient is trying to bear weight. So rather than leaving the joint like that, sometimes the orthopedic surgeon will fuse the two components together so that at least patient can bear the weight in that joint, though the movements are severely restricted. This is known as arthrodesis. And you're right, arthroplasty can also be done. Okay, arthroplasty. So this is another option.